if you have keenly observed the TV advertisements, if you observe the Horlicks advertisement, you will surely not miss Dr. Varsha ma'am. Dr. Varsha ma'am is a renowned nutritionist of our country. She is the former president of the Indian Society of Enteral and Parenteral Nutrition and currently a very active member of the Indian Association of Parenteral and Enteral Nutrition. And she is very much involved in most of the enteral nutritional activities in the country. She's got a wide number of publications. She is an invited speaker, invited and acclaimed speaker both nationally and internationally. I feel one of the most important issues is ability to detect malnutrition at an early stage, which is very important for us to give any cost-effective interventions. All the interventions which we are speaking would be possible only if we are able to screen at an early age, screen correctly, screen with high degree of sensitivity and specificity. So to enlighten us on this issue, today Madam is going to speak on malnutrition universal screening test must, which is both a concept and a screening tool.
I stand before you to tell you the most important aspect of malnutrition, that is the malnutrition that we see in the hospitals. We do have a dietary department where you have a dietitian whose picture is that of a cook, an official taster, a rotund person who comes out with very bland recipes for the poor, helpless patient. And the patient looks at the tray and doesn't consume anything. This is how, and invariably you have a dietary department that is in the basement or somewhere in the remote corner of the hospital. No importance is given ever to nutrition as such. And that is the reason things have not changed over the years, though we have national nutrition programs, and my previous speaker was talking about breastfeeding. With all due respects to him, as a woman, I have one thing to say, that it's women who have breast and only they know where the problem is. I can say this with authority because for the simple reason, I do have mothers who are sent to me saying that breastfeeding is a problem. From the community medicine, from the OPs, from the pediatricians, I do get a referral to say something is definitely wrong, failure to thrive. And when I look at it where the problem is not with the failure of a mother wanting to feed or breastfeed, but it is because on the mechanics of what needs to be done. The two major issues where I got involved, one was with the MS Swaminathan Foundation that wanted to find out how to empower women on breastfeeding. And we found the first hurdle was that we were asked to do the study in Ramchandra Medical College. And when I asked the mothers to talk to the students in the pediatric department to talk to the mothers refused to talk, saying that all PGs were males, you don't understand my problem. I'm talking about community. I'm not talking about anybody else. The women refused to talk to the PGs, saying that you're men, you don't know our problems. I had to overnight change the whole protocol and put in only the women PGs. I still have the problem. The women turned around and told me, you're unmarried, you don't know what I'm talking about, get lost. So then I had to search for PGs who were married and then put them. And then the third problem came in, because then the married PGs came and said, yes, Dr. Varsha, we will do the work for you, but we need a solution too, because I was given maternity leave for 1 month and I've left my baby home and I have the problem. So give me a solution first before I give solution to your women whom you're calling on the study. So this is where empowering women comes, and that is where the breastfeeding comes. That problem is always there. Anyway, we will move on to the topic of the day. We need to identify first the level of malnutrition that is existing in the population that comes to us in the hospital. And how do we go about doing that? So I'm going to basically cover today on nutrition screening protocol for malnutrition in hospitalized patient. This is the first step. The objective of my presentation is to highlight to you that we need to apply this nutrition screening and assessment because it is the most optimal assessment tool to identify and determine the patient's nutritional status, apply aspects of medical history and physical examination to the assessment of nutritional status, recognize 2 risk factors that are associated with malnutrition, evaluate available lab data in relation to the nutritional status of patients receiving nutrition support, and then determine appropriate candidates for nutrition support therapy. This is basically the objective of why we must start with the nutrition screening program. Next one. Nutrition support is basically the word that is used for giving nutrition in non-healthy state. We do not talk about nutrition support in a healthy individual. This is a diet prescription for individuals who are unwell and may require an intake that is higher or conversely restricted in certain nutrients, and may include those with poor intake, loss of appetite, unintentional weight loss, infectious disease, acute and chronic illness, disorders of GI tract, kidney or liver, and injuries. Next one. The clinical implications of what I showed in the previous one is that it is an alternative to more costly medical procedures. Medical nutrition therapy provides the metabolic substrate needed for recovery and prevention of complications. And an appropriate nutritional therapy can prevent negative health outcomes and reduce medical resource utilization and medical costs. This is the reason why we have to give emphasis on nutrition screening. Next one. Time magazine gave a headlines and said malnutrition is a time bomb warning. What is malnutrition? A pathologic state resulting from a relative or an absolute deficiency or from an excess of one or more essential nutrients. And we have been taught earlier that we have two major forms. I did mention about two risk factors. And so marasmus and kwashiorkor was the standard textbook teaching. If marasmus is a result of long-term deprivation of nutrients easily recognized by a wasted cachectic appearance, and kwashiorkor is a result of a deficit of protein in relation to calories and may develop over a shorter period and manifest as edema due to hypoalbuminemia. But in clinical practice, we don't see exclusive marasmus or exclusive kwashiorkor. What we basically see is a mix, a marasmus-kwashiorkor mix, which is a combination that results when metabolic stress is imposed with pre-existing malnutrition. Next one. Also, the important thing is that earlier, you could never ever write on a medical record the cause of death as malnutrition. That has changed now. Codex Alimentarius and WHO has put malnutrition as a reason for cause of death. It has been identified as a common problem among hospital, home care, and other alternative site settings, increases the cost of health care. And most importantly, malnutrition is associated with higher morbidity and mortality, slow wound healing, longer hospital stays, and a higher rate of complications. This is the reason why the health cost goes up. Next one. Incidence of malnutrition ranges about 30 to 55% in different specialties in which the people are admitted. More so you will see in orthopedic, where you see almost 90% of them who are malnourished. Nutrition screening is a tool that helps identify patients at risk of malnutrition, and this was first documented in Nutrition Clinical Practice Journal in 1993. Next one. So, I now come to the crux of the screening itself. I'm not going to talk about assessment today. It is essential for effective practice of nutrition support. The ability to efficiently and effectively determine who needs medical nutrition therapy via nutrition screening and assessment processes. Determine the best time to initiate nutrition support and establish which route of nutrient delivery is most appropriate. Are we going to continue giving oral? Are we going to give them supplements? Are we going to look at enteral nutrition or parenteral nutrition is a decision that the process of screening and nutritional assessment allows us to do. Next one. So screening for nutrition risk is a process of identifying patient characteristics known to be associated with nutrition problems. Its purpose is to quickly identify individuals who are malnourished or at nutritional risk, exhibit nutrition risk factors or indicators, have the potential for causing malnutrition if it is not already present, and once you have identified the patient and classified as at risk, these are the candidates who have to be taken care of by the nutritional assessment and intervention. Now, why is it that we want to do a screening program prior to the nutritional assessment as such? Is because, next one, we have always the staffing and budget limitation. each patient requires a minimum of about 60 to 90 minutes to be assessed and counseled. And this, when you look at the sheer numbers that are there in the hospital and the number of dietitians that you have in the dietary department, both of them don't concurrently go hand in hand. And that is the reason every individual patient. So a screening for nutritional risk is a complete nutrition program that takes the characteristics of the population as such from which it is developed. And so you can find that it can be taken care of by healthcare professionals like dietetic technicians or dietary manager or a nurse or a physician. Anybody can do the screening, does not require major expertise, except that we have created a protocol that is very much true for that particular hospital setup. Next one. So nutrition screening can be defined as routinely to be undertaken to identify individuals within a population who are at risk from under or overnutrition. The screening procedure should be rapid, simple, acceptable to patients, undertaken at first contact or soon after, carried out by nursing, medical or other staff, provide an outcome that links to an action plan, and it should be repeated at intervals. This is the definition of the nutrition screening process. Next one. There are different tools that are available. The tool of choice should be appropriate for the patient population, have validity confirmed by a peer review publication, have suitable cutoff points to maximize sensitivity and specificity, minimizing false positive and false negative results, provide outcomes that can be acted on when appropriate. This is where we link it to the care plans, reflect local needs and overcome resistance to implementation, and be associated with the staff training program. Next one. These are the predisposing factors that we should look for when we are talking about screening. So not all of them can be accommodated, or maybe we do need to accommodate all of them depending on type of population that comes to the hospital as such. If you have a pediatric versus a geriatric, two different aspects of in the hospital, the wards taking pediatric, you might have to look at these in various combinations. So I have just listed all the predisposing factors: chronic disease, poor dentition, involuntary weight change, decreased appetite, drug-nutrient interaction, nausea and vomiting, dietary supplement use and or abuse, bowel problems, inappropriate weight for length or height, increased metabolic requirements due to stress of major surgery or trauma, recent surgery, illness or trauma which altered nutrient intake, and inability to ingest or absorb adequate nutrition for greater than 7 days. 7 days is the guideline that is provided by the Cochrane group that has gone into a lot of studies, and they've said that anybody who is not going to be, but the latest guidelines coming from IAPEN, American Society for Parenteral and Enteral Nutrition, has brought it down to less than 3 days. Anybody who is not going to be consuming food for 3 days post-surgery or post any intervention must be considered as a candidate who is at malnutrition risk. Next one. Kushner and colleagues had defined nutrition. He was the former president of IAPEN, and in JADA 1994, he had defined nutritional assessment as a comprehensive approach of defining nutritional status, and it is as per that definition which I told you. It takes us about 60 to 90 minutes to do the assessment. And he then went on to define and said that screening programs are important to suggest the risk of malnutrition, so that a thorough assessment is necessary to verify the presence of malnutrition. So once you've picked up a person on the screening and flagged them, only then the dietitian takes over to see that assessment is taken forward as such. And the nutrition assessment builds on the information that is obtained during the nutrition screen itself. Next one. Now I am going to highlight to you the one tool that has been universally used. It was developed by the British Association of PEN. It's a multidisciplinary association considering the most scientifically robust, practical and versatile nutrition screening tool. And it is used in different care settings, including hospital inpatients and outpatients, care homes, GP surgeries and health centers, as well as in the community. Next one. With Different groups of adult patients, you can use this must on elderly, surgical, medical, orthopedic, those requiring intensive care, mental health care, pregnancy and lactation. Of course, there is some amount of adaptation that is required, is what is suggested by BAPEN. It can be used by different healthcare professionals, as I said, nurses, doctors, dietitians, healthcare assistants, and students to detect both undernutrition and overnutrition. This is where the whole gamut of requirements in a screening has been covered by the must tool. Next one. It is actually a 5-step screening program. First, you have to measure the height and weight to get a BMI score. The whole tool itself provides you a chart wherein you can enter the height and weight and get a BMI. You don't have to sit and do the calculation. If you do not get a possibility of getting the height and weight by the regular means, like for example, you get a patient who's come comatose, who's just been wheeled in and you cannot make him stand up for a height, then they have given additionally alternate suggestions on how you can measure the height and weight of such patients. So alternative procedures have also been delineated in this must tool. The second step is note percentage unplanned weight loss and score using the tables provided. So if there has been weight loss of about say 5% within a month or 10% within what time. So they have worked out on those scores, unplanned weight loss, and they have given you a score for that. And the third step is that you establish the acute disease effect, and for that also the table provides you what comes under acute disease procedure, and you can score on that third one. So what you need to do is, in the fourth step, add scores from steps 1 to 3 together to obtain an overall risk of malnutrition. And the fifth step is that having done the risk of malnutrition, you can provide and make yourself a guideline or a local policy on how you're going to care for a patient who has this score or this score. It is very easy for you to do that. Next one. For example, they have said, if you put a person on a low risk, then you do the routine clinical care, repeat the screening. If it is in the hospital, you do it on a weekly basis. If it is a care home, you do it on monthly basis. If it is a community, you can do it on annual basis, especially for special groups like those people who are greater than 75 years of age or something. So this is the guideline that they have provided on management. If it is medium risk, you're supposed to observe this person on a regular basis. You have to document dietary intake for 3 days if subject is in hospital or care home. If improved or adequate intake, little clinical concern. If no improvement, it is a clinical concern and you will have to develop another local policy. So this is the guideline that is provided for the moderate risk. And for the highest risk, you straight away have to take a decision that this person must be treated. So you immediately refer a person to the dietitian, nutrition support team, or implement the local policy that you've developed for it. You must monitor on improvement and increase overall nutritional intake. You also need to monitor and review the care plan. Same, they've said if it is hospital, you do it on a weekly basis, care home monthly, and community also monthly once they are in the high risk thing. So this is a protocol that the screening program that I want to share with you here. It is available. In fact, Shivakiran tells me that he has already written to BAPEN and has made these screening protocol programs available to us. And my appeal would be those of you who are in the hospital setup to consider that we implement the screening protocol at every level. We develop one for the hospital saying that we have various categories of patients that are coming in, and then we develop what is it that we would look for, flag these people, and then refer them for further management as such. So this is very, very essential. This is the first step in trying to see that we establish a very effective nutrition support system in the hospital. Next one. This is what the whole thing looks like. You have it in 3 parts. You have the tables for marking your BMI. You have the, for scoring, everything is available to you as a tool. This is how they printed it. It is available. It is there even on your internet. You can access it on your website. And it is also made available, I understand now, with Shivakiran. So you could acquire this and take it as a part of a policy to be implemented. Next one. This is the program on the other side of the leaf gives you, you know, what should be the score that you need to give as per the BMI. If your BMI is greater than 20, then it is 0, and 18.5 to 20, it is 1, and less than 18.5. Similarly, for unplanned weight within the 3 to 6 months, they have given scores. And if patient is acutely ill and there has been or any chance of no nutritional intake for greater than 5 days, you straight away give a score of 2. And then you add the scores. If the score is 0, it is low risk. If it is 1, it is medium risk. And if it is 2, then it is high risk. So this is the tool that is developed. A lot of work has gone into by the British Association of Parental and Enteral Nutrition. Next one. They have also given a sort of a care plan depending on this, what you need to do. This is mainly for the British population, but we need to develop a policy and say, what is it that we are going to do as such? Now, the reason why I say that is that I have trained in UK as well as in the US, and when there is a policy, they have usually a manual. For each of the disease, depending on the age, the sex, the type, the degree of disease, and the dietary department, or everybody has got together and they write out a manual and say, the doctor just has to refer onto that manual and say, if I see this category of patient, this is what will be given by the dietary department. So there is an indication saying that the diet as referred to in the manual is what needs to be given. We have a very long way. We in our country, I suppose Tower of Babel was in India. Because, you know, every 500 meters we have a different dialect, a different language in every state, a different cuisine, okay? And so I think the task before us is pretty Herculean. And this is where we need to consolidate and say how we are going to, depending on different type of food, traditional way of eating, the impact of what is coming into our country. We are not happy if we get apple that is locally grown. We are very happy when it comes imported from Australia with all the wax and everything. We talked about, I mean, this particular session is also going to talk about adulteration. And so we are very happy when all these additives and preservatives and everything and comes over across the seas, we pay through our nose and we buy it. So this is where the problem comes in. So we need to have a policy which says, no, we are going to encourage. There is also a small myth, you know, of everybody who thinks that if you want to avoid cardiovascular disease problems, then you have to stop eating your traditional breakfast and start eating oats. And I'm horrified in the way the people eat oats, okay? It adds to the problems, does not subtract. In fact, it not even adds, multiplies to the problem. Because how oats are eaten in our country, it is made into porridge. And the porridge has more water. And then out of fear, if you're diabetic, no sugar is added. So ultimately, if you will analyze, 2 tablespoons of oats is all that is gone in. And how does that suffice in terms of calories, proteins, everything as a requirement? It does not suffice. But you have industry which tells you oats is the best thing and that you need to take, or you need to take cornflakes. But if you have rice flakes and rice, puffed rice in our country, the only time we took those things was only as tea time snack and never as breakfast. But we have the world now telling us that you must eat corn as the best thing for breakfast in the morning. So this is where I'm talking about policy. We need to develop a policy in our say and say, what is it that we want to give our population as breakfast in the morning? What is it we want to comprise when it comes to lunch? What is it dinner? How much calories, how it is provided? Because there is something called satiety. You need to feel satisfied with what you're eating. It's not just a question of taking food and putting into our mouths and filling the stomach. Stomach, after all, is just a reservoir. It's just a receptacle of getting the food. But how we respond to the food is very, very important. And now IAPEN has brought out a manuscript on phytochemicals in critical illness. If you look at phytochemicals, it comes from the food that you are growing in that geographical environment and you're used to eating. So it is not just chemical-based foods that are going to really solve our problems. And this is where technology has to give us foods that are traditionally made but acceptable in form of convenience. So they have given a chart which is very much for British population on what needs to be given to a person if they find them at 0 or 1 or 2, that is low risk or moderate risk or high risk. Next one. So this is where they have elaborated on this plan. I just tried to capture it for you to say what is available on the pamphlet. I don't want you to exercise yourself trying to read what it is. It's not possible. Next one. So my key points for the presentation today is that nutritional assessment and intervention are not dependent on the existence of a nutrition or metabolic team. In the US, in the UK, you have team. You have a physician who leads the team. You have a dietitian. You have a pharmacist. You have a nurse. Sometimes even a physiotherapist is added. And these are called as metabolic nutrition teams or nutrition support teams. But in our country, we don't have anything happening. But let's not try to emulate and say that we will wait till the team comes. Not necessary. A nutrition screening tool is one which can be used, as I said, by a variety of people. So any one of us who are very much interested in our patients need to pick up this tool, get familiarized with it, and start making an assessment on who is going to be at risk of malnutrition. This is very essential because prevention of malnutrition mandates early detection and intervention, and nutrition and metabolic support is not to be reserved for malnutrition because prevention is better than cure. So we don't have to wait till malnutrition sets in. We don't have to have a person with burns or cancer or cardiac cachexia to get into an absolute abysmal level and then start trying to bring them up. So as soon as the screening process allows us to pick up the degree of malnutrition that is present and then start them on nutrition support at an earlier date. So I think the last one is a thank you slide. Thanks for the attention. I hope I have appealed to you that the need of the hour is that we must start off with nutrition screening on a very mammoth scale, and only once we do and identify the level of malnutrition that is there in our patient, once we give a label, then it will mandate that we do something about it. We are not even identifying degree of malnutrition. When we are not picking up malnutrition, it does not appeal to us to start treatment for this patient. And I would want to conclude by what Sinclair said. Nutrition, medicine arose from dietetics. Pythagoreans, including Hippocrates, used diet as the main line of therapy and drugs when diet failed. Unfortunately now, we use drugs as the main line of therapy and diet when drugs fail. Thank you very much.
Thank you, ma'am. Because the earlier speaker had to leave, he had a flight. I think we can allow 1 or 2 questions. Yes.
Ma'am, I'm Dr. Sharan, Professor of Medical College. I have a question regarding the screening tool, ma'am. You said about the risk categories. Based upon the BMI of British population, can we apply the same risk classifications for our Indian population? Or one more question is, are there any studies who have validated such tool in India?
Very great question, and the reason why I was asked to come and make a presentation today was to appeal to my Indian population brethren here that yes, we do need to work in this area of creating our own standards. Definitely, at this point of time, we are using the universal tool, but we have to make an adjustment. Again, if we are looking at the height and weight, there is a major controversy that is going on as far as BMI is concerned by itself. But we are not only using BMI. We have used that as the first step. Then we are also looking at the second step of acute illness and all those other things, okay? But again, I'm saying this is a tool that has been created by the Britishers for the British population. It will be our job to create one which is acclimatized and made possible for India. And that requires each one of us present here and many who are not present but who would be interested in it and whom we can get interested in. My job today was to market this particular tool's presence to say that we need to create something for ourselves. As I said in the morning speech itself, that we are so used to taking Western standards and trying to implement in our country. No, we need to create our own standards. procedure and said, if you put these components together, you will get an answer. Now, to create our own BMI is a mammoth thing. We do need to do it. Until then, something is better than nothing. We do need to use it. But once we start using the scales, we do realize, and I'll share this as a part of the question they were asked. When I teach my students, I tell them that the fallacy of looking at only BMI. You see 160 centimeters, minus 60, okay, I mean minus 100, the Borka index that you have for males, and multiply by 1 for male, right? So 160 centimeters minus 100 is 60 kgs. But look at it in terms of the age of the person. You see a 60-year-old male having 160 centimeters and 60 kgs versus a 16-year-old, 1/6 male. You will find the 60-year-old has a tummy that goes 2 feet ahead of him versus the 16-year-old who has got a broad shoulder and a tummy that is tucked in. So you just can't go by the value itself. You also need to look at the implications of it. So your question is very valid, but the answer is we have to put it together.
We had one more question.
This is Dr. Srinivas from Abbott Nutrition. My question is pretty similar to what was just now asked. We do not consider BMI as a good measure of obesity. So do we think that waist-hip ratio should be the more appropriate tool in Indian population? And also in acutely ill patients, how do you measure standing height and weight? So is there an alternative to this?
There is an alternative, yes. My answer is the same in the sense that I have been struggling since I trained, and I have been in touch with Abbott, USA. I trained in Chicago, so Chicago Medical School, and I am still struggling because I got the calipers from there to measure the knee heel length, converting it into the height of an individual. I'm still not able to, get the weighing machines that can weigh the patient who is supine and unconscious. So we do have limitations, but as I said, they have given you alternatives on how you can measure or make an assessment of height and weight for people who cannot be on the weighing machines. That is definitely a possibility. And as I said, BMI is a controversy that has been going on, but what I said was, at the moment, this is the only tested tool for screening that is available. Nothing prevents us from creating a tool that is India specific. If we feel that no, we don't want to go by BMI, then what is the next alternative? We need to take a consensus and make a conclusion and then develop something on it. Because all said and done, when it comes to the measurement of somatic protein in an individual is only by height and weight. The use of lab is possible again, but it is, if you're taking 24-hour creatinine, urinary creatinine, that is a tedious job, not without any its own limitations, but again that is related to the height. So even if you were to eliminate weight and you want to use only the height, using the 24-hour urinary urea creatinine excretion, you're still in a problem. Okay, there is another tool, but that is more of a nutritional assessment tool where energy metabolic profile, ANERGY, energy metabolic profile by Mitch Kaminsky Jr., he worked out on this, makes use of 3 compartments, somatic protein, visceral protein, as well as the dietary protein in terms of immune protein, and then looking at nitrogen in and nitrogen out. But that is not a screening tool, that is an assessment tool. So the only one that we have at this point to make a start with is a must, from which, having said the predisposing factors, we need to take a consensus and develop our own screening tool. That is what I want to appeal to you.
Excuse me, madam. Madam, I'm Dr. Mauneshwari from Raichur.
But just a minute, she's there talking. 1 minute.
Can we make ICMR standards for standardizing these?
ICMR standards, do they exist? They don't.
Yes.
No.
For heights and weight.
The technical series number 18 doesn't exist. It's obsolete. We don't have a new one.
Now they have a refined one, madam.
That's what I'm saying. There are still question marks. National Institute of Nutrition had a meeting some months ago, and they still have not adopted and said that they want us all to use that one. That's the problem. We still have to wait for the consensus, because National Institute of Nutrition, Hyderabad, has to give a consensus After all, NIN is nothing but part of ICMR.
So probably the last question and point-to-point clarification.
Has directed the department to identify malnutrition in pregnant women by doing regular screening programs. So what are the what is the parameters that we can use to screen malnutrition in pregnant women? Because if you take BMI for non-pregnant, non-lactating mothers, it is less than 18.5. But in pregnant women, what is that we have to?
There is a modification that is suggested by BAPEN itself. Okay, I have not looked at, but at Ramchandram, one of my PhD candidate worked on malnutrition in pregnancy. And we tried creating a score by which, what are the different components we can put in. I will keep in touch with you and then we can work it out on that part of it. Yes, I will share the components because then, what we used to create that particular score. We did a K factor in pregnant women and looked at it. This was almost about 6 years ago that my PhD candidate did this work. I'll just go back to it and share with you on that. It doesn't come to my mind.
This anthropometry, biochemistry, clinical, and as well as
Yeah, but
dietary.
that comes under your nutritional assessment. We are talking about screening.
Ma'am, as the same, we can apply on the screening also. So that little bit, as we all are discussing.
Develop one. Welcome. You're welcome.
I just wanted to share that I did, but the only problem is that I don't have any review of literature about these methods. That nobody
You can refer the thing. I'll give you guidance on what is possible because if you have developed something which you have tried it out, we have to do the specificity and sensitivity test for it.
Yeah.
And if it's good enough, then we have any number of people who will support us to market it. You can share that information with me. I'll put you onto the people. I don't want to take the credit, but I'll put you onto the people who do it. Sure.
Right.
Yeah.
Thank you.
Probably one-on-one discussion can continue. So on behalf of the organizing committee, I sincerely thank Dr. Varsha ma'am for enlightening us with respect to a universal malnutrition, universal screening test for risk assessment. So I request Professor Dr. Neena Joshi, who is the Professor and Head, Food Science and Nutrition Department from the University of Agricultural Sciences, to hand over a small memento of our appreciation to Dr. Varsha.